So welcome everybody. This is the CSF author interview with Dr. Gustavo Citera, and we're talking today about his recently published paper in the Journal of Clinical Rheumatology on the incident rates of interstitial lung disease events in tofacitinib-treated rheumatoid arthritis patients. Hi Gustavo, welcome so much. Thank you so much for giving us your time. We appreciate how busy things are. Can you just fill us in a little bit about your background and what's happening with this crazy pandemic in Argentina at the moment?
I'm a rheumatologist. I'm the chief section of rheumatology at the Instituto de Rehabilitation Psychophysical. This is a tertiary center in Buenos Aires, and our main interest is in RA and spondyloarthritis.
Okay. And the pandemic, how is it affecting?
So the pandemic is ameliorating in Buenos Aires, but it's high in other provinces in our country. So we don't have a strict quarantine today. So most, restaurants are open, but not schools, for example. Not most schools are open. So we are trying to pass this crazy thing.
Has it changed much of the way you practice medicine at the moment?
Yes, absolutely. You know that we start more with telemedicine, and we have to, and also these things that we have many talks and roundtables through the internet. So this changed completely our life.
Okay, so let's get back to this paper. Thank you so much for talking to us about it. Can you tell me a little bit about why this paper was done? What was the reasoning behind doing this particular post hoc analysis of all the tofacitinib studies?
Well, we have also one of the questions that we start was what happened with JAK inhibition and interstitial lung disease. And we have three explanations regarding the effect of JAK inhibition in interstitial lung disease. And the first one is experimental, and there is a very interesting study by Shou Shendo from Kobe University, recently published in Arthritis Research and Therapy, where they assess the effect of tofacitinib on the zymosan-induced ILD in SKG mice histologically and examine the cells infiltrating the lung by flow cytometry. And they observed that tofacitinib significantly suppressed the progression of ILD compared to the control mice. And the way was that tofacitinib promote myeloid-derived suppressor cells expansion while Th17 cells decrease in the lung of treated rats. So these cells stimulated by JAK inhibition suppress T cell proliferation and Th17 response and ameliorates ILD in that experimental model. The second is that you know that nintedanib, JAK inhibition against TYK2 has shown antifibrotic, anti-inflammatory, vascular remodeling effects in several animal models, and the recently published also the inbuilt study in patients with ILD with other diagnoses, including RA, demonstrate efficacy. And the third one that motivates us was that the presentation of some case report at local meetings in Latin America showing an improvement in ILD in patients with active RA treated with tofa.
So that's very interesting because it has implications for interstitial lung disease across many other indications. So that's very interesting, especially the antifibrotic properties, I think would be critical. I've always found ILD very difficult because by the time people are very symptomatic, there's a fair amount of fibrotic damage. And like end-stage kidney disease, once you've got damage, and trying to catch it early and whatever. So tell us the methods for this paper. What did you do?
Well, actually, what we do, we know that ILD is detected if you use CT, high resolution CT scanning up to 60% of patients with RA. But unfortunately, we cannot do this as a screening, the radiation and those things. So one thing that we used in the past was the pulmonary function test. And now we are starting with ultrasonography of the lung. So with ultrasonography, our rheumatologists doing ultrasonography can detect these B lines, and we can select patients to perform CT scan.
Okay. So in this study, you took the 9 pooled TOFA studies, the 2 doses,
yeah,
and it's fair enough that people who had very symptomatic pulmonary disease wouldn't have got into the study, but how did you go about actually doing the study itself?
Well, actually, it's right what you say, but you know that patients with known ILD could not enter in this type of studies. And in all patients in these studies, we request for a chest X-ray at least in order to detect latent TB. So
TB.
This is one way to not incorporate patients with obvious ILD, but we cannot exclude that some patients with asymptomatic or not detectable ILD in the X-ray can be included in the study. But what we did in the study specifically was that the potential ILD events were adjudicated by 3 independent pulmonologists, and they select patients improbable, compatible with the adverse event, with supported clinical evidence, with that means pulmonary function test or CT scan, and possible, that is compatible with no supportive, but 90% of cases were probable.
Okay, so I just wasn't clear about what an event was. Was it acute breathlessness, or was it a chest infection, or what made it an adverse event?
The adverse event was selected by the investigator as an event with clinical symptoms, or because the investigator performed or detect in the physical exam something, so they perform a complementary test and detected the ILD.
Okay, so tell us a little bit about the results of the study. What were the main
findings?
In
this study, as you mentioned, we included all phase 1, phase 2, phase 3, and phase 4, and long-term extension studies with TOFA. And we included 7,061 patients. That means a patient years of exposure more than 23,000. And the data included up to 9.5 years of exposure to TOFA. And we observed 42 patients with ILD event, that means 0.6%, with a median time from the first dose of treatment to ILD event of 1,144 days. And we performed first a case match control analysis. We took these 42 control cases, and we selected 210 controls matched by age and by sex. And the ILD event group had a numerically higher proportion of patients who were from Asia, not your country, mostly from Philippines, Thailand, and I don't remember, Malaysia. Only one case from Australia and New Zealand that were together.
Yeah.
And previous or current smokers were seropositive for rheumatoid factor or CCP, had higher disease activity versus controls. And then we perform a multivariate analysis in the whole population, and we identify older patients, that means older than 65 years old, and current smokers as 2.4 and 2.9 times more likely to have an ILD event versus younger and patients who had never smoked. And the most important finding, I think, is my opinion, is that we observe an association with disease activity. We observe that for every 1 unit increase in DAS28, patients were 1.3 times more likely to have an ILD event.
Very nice.
Yeah. Also, we observe more frequent serious infections in patients with ILD, and the frequency of all-cause mortality was higher in ILD patients, 7.1 versus 1.6 in patients without ILD.
So that was a lovely summary. Did you see a dose response 5 going to 10 milligrams of TOFA?
No, we did not observe any difference. Actually, the incidence rate for the 5 milligrams was 0.12, and for the 10 milligrams was 0.10. And yes, it's important that in the placebo was 0.32. So the incidence rates were lower with TOFA as compared to placebo.
Sure, but the numbers in placebo are pretty small and quite wide confidence intervals.
Yes,
absolutely. And did you see any difference with mono versus combo methotrexate? And were you able to see if methotrexate added an element of interstitial lung disease risk?
No, absolutely not. Most patients were on methotrexate and incidence rates were numerically similar. I think that 0.16 in the monotherapy and 0.18 in the combination therapy. And but most patients are on methotrexate. We have some patients on other conventional synthetic DMARDs, but most of them 70% on methotrexate.
Okay. It was interesting, the association with mortality, but it wasn't sort of serious infection of the lung that caused the problem. I got the impression it was other diseases.
Yes, probably. The most deaths were associated with infections in general. Yeah.
Right. Okay. And was corticosteroid use a risk factor for ILD, or may it be a little bit protective?
No, we did not observe. Also, we did not observe any difference in patients receiving steroids or not receiving steroids in the incidence rate.
So very nicely done. So over 65, the Asians, where we hear these reports of pneumonitis from a variety of disease-modifying drugs, which we don't see in our own population, high disease activity at baseline, and smokers in particular. So any take-home messages for the rheuma? We must stop our patients smoking because it seems to drive seropositivity and bad outcomes.
I think that it's important that we confirm the data on the factors associated with the risk of ILD and the importance of identifying these factors by the treating physician, because those patients, today we can perform some non-invasive methods to detect asymptomatic ILD. And I think, Peter, that our study highlights the importance to control disease activity to minimize the incidence of this important complication or extraarticular manifestation. So this put on the table that RA is a systemic disease, not a disease of the joints.
So thank you very much for your time. It's been a pleasure to have a chat. This has been the CSF Author Interview podcast. If you'd like to know more about this very nice paper, shows that it's important to treat inflammation and people have better outcomes and to do something about smoking. This paper and others are uploaded to the CSF website this month. You can find detailed slide sets available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcasts from, and give us some feedback and let us know what you think. And Gustavo, thank you very much for your time. We greatly appreciate it. This is Professor Peter Nash in the Griffith University in Brisbane, and I hope you've enjoyed our chat. Thank you very much.